Go.
Hi, welcome everybody to this exciting first aid session. Hope you can hear us well. Otherwise, please use the Slido to just write comments and questions. My name is Teresa, and I'm here as a moderator. I'm working in ILCO in the First Aid Task Force, along with my co-moderator.
Hello, everybody. My name is Pascal Casson. I'm an emergency physician in Paris and head of the Global First Aid Reference Center of the International Federation of Red Cross and Red Crescent. We have the pleasure to work with Jacqueline.
Yes. Jacqueline, would you like to say hi?
Hello, everyone. Thank you for having me as a co-moderator as well on this session. I'm the ALS representative with the Young ERC, and I'm very happy to be here with you guys today.
Fantastic. So we're going to have two nice presentations. And who will we be listening to, Pascal?
Yeah, we have the pleasure to have four panelists who knows very well, of course, first aid and resuscitation in general. Two are coming from Belgium, of the Center of Evidence-Based Practices, Amy and Irvine. And in the other hand, we have also Salome from the Global First Aid Reference Center working in Paris, and also Emily, who is working for the International Journal on First Aid Education. And all the panelists will give you, I think, an exciting information on a remote area and how to teach and how to take into account the remote and the crisis area. So,
yeah,
go ahead. Who you share your screen.
Fantastic.
Hello, everyone. So here are the conflict of interest. We are employee of the Global First Aid Reference Center with Pascal, and Emily is from the International Journal of First Education. Emily the book work closely with the Cochrane First Aid and is an employee of Belgian Red Cross Flanders, along with Irvine Kendra. So it's who we are. And here we wanted to give a little bit about the Global First Aid Reference Center, because we are here because we are trying to connect outside the Red Cross, Red Crescent world. So our role is to harmonize first aid and facilitate knowledge sharing among countries along 192 national societies. For that, we are promoting an evidence-based approach in research in order to provide quality first aid education. And we also have a strong role in advocating for first aid through events like World First Aid Day or the famous World Restart a Heart Day that you all follow, I'm sure. And also we directly go with National Society to support program directly on the field through evaluation and technical advice that we try to adapt as much as possible to the community, and we will have the occasion to talk more about that. We are coordinating and leading the Global First Aid Network for the Red Cross and Red Crescent National Societies, and we will provide some example outside Europe. And finally, we develop resources and make economies of scale. So it's really important for us to continue collaborating with all the first aid organizations like ERC, and also Cochrane, Center for Evidence-Based Practice, and International Journal of First Aid Education. I think I can hand over to Emily to present one of our main publications, which is the International First Aid Recitation and Education Guideline 2020. We have our own guideline, truly inspired by ERC guideline also. We work hand in hand, and Emily will explain about the specificity of it. So over to you.
Thank you, Salome, and hello, everyone. The IFRC's First Aid, Resuscitation and Education Guidelines, which came out early last year, represented a sea change in the way that first aid education was presented to both trainers and learners. Not only did the new online version make them far more accessible globally and in a practical sense, the language and the emphasis on the practical application across a broad variety of contexts and circumstances made them much more relevant to learners of all kinds. The guidelines are created using systematic reviews and other evidence as well as input from experts across the full range of topics and from every region of the world. And the conscious effort that has been made to be inclusive across aspects of disability, race, gender, as well as socioeconomic position adds to their wide appeal and their welcome from the Red Cross and Red Crescent National Societies across the world who are charged with implementing them. So in this session, we are going to focus on the more challenging context covered in the guidelines, those of remote, disaster and conflict contexts. And my role is to introduce you to these through the evidence base that we use to create them. And this in itself is a challenge because, as you might expect, the evidence on these particular contexts is full of gaps and voids due to the fact that they are difficult to study and even more difficult to test different educational approaches in. Throughout the IFRC 2020 guidelines, each topic that appears, whether it's clinical or contextual, considers the different mechanisms for the learners. And that includes both the scientific evidence and the pedagogical evidence. And as such, each section includes educational considerations for the trainers and the learners. The provision of facilitation tips and tools that has been worked on by the reviewers and experts from a mixture of more developed and less developed countries, and the IFRC's sister body, the ICRC, the International Committee of the Red Cross, provided additional insight to ensure that the more challenging contexts we're talking about today are represented within those local implementation strategies and the educational activities. So, why are we talking about this topic? And what do we mean by fragile contexts? This definition that you see here, this definition of increased danger, limited or absent medical supplies and lack of access to healthcare forms the foundation of the challenges presented to the first aider in all three contexts. Increased danger could be because of environmental conditions, such as being stuck somewhere remote when conditions become extremely hot or cold, or physical conditions. In a disaster context, this could be collapsing buildings, for example, or security conditions. In conflict, you could be under fire. In all three contexts, but particularly conflict settings, the Dr. ABC acronym, which has featured in first aid education for decades, placing check for danger as the first action of the first aider, takes on a hugely increased importance, and education content needs to be explicit that safety and security of first aid providers must be considered and secured before providing care. Whilst the concept of checking for danger has always been a key aspect of first aid learning, in these fragile contexts, its importance is really magnified because of the vastly increased likelihood of real, serious, and immediate danger to the responder. After safety and security considerations, special emphasis has to go to other limiting factors of the specific setting, like having no first aid equipment, or the need for stabilization for a longer period of time because of no professional health care that is quickly available or reachable. And also the idea of unfamiliarity of the area with limited communication opportunities. So helping learners to cope with these challenges whilst stabilizing life-threatening conditions such as blood loss or airway management is the educator's greatest challenge. Trainers have to support first aiders and first responders to learn to deal with all these circumstances, often under very difficult conditions and in an appropriate and an efficient way. The IFRC guidelines are built using the chain of survival behaviours as a framework for learning. Preparedness features in the first domain of the chain. When we think about the three fragile contexts, preparation for being in a remote area or in a place where natural disasters could occur should be central for any learner. Communities that are remote and often have ingenious or creative response mechanisms for when someone is ill or involved in an accident. And there is a growing body of evidence in the public field about different community response mechanisms. In instances where people are visiting remote areas where they are not used to having limited or no access to professional help, and are likely to face poor health outcomes if they're not adequately prepared, first aid education focusing on preparedness and self-care can be absolutely critical. The evidence base which underpins these aspects of the guidelines includes studies based on more recent events, such as the response to hurricanes affecting the US, field manuals for those working in conflict and disaster settings, and insights from people who work in these different kinds of contexts, such as mountain rangers or guides. Much more evidence is needed, particularly as technology improves and affords different ways of getting information and accessing help. And we're now going to hear some really interesting case studies of how communities prepare and adapt their first aid education to suit the conditions that their learners face. So now I'm going to hand over to Salome.
Thank you very much, Emily. So it's true that while talking about those contexts, either remote conflict or a disaster area, we don't have the same means at our disposal, and we have to take into account the fact that the emergency services might be overwhelmed. So that's why it's important for the Red Cross and Red Crescent national societies to prepare the community to build their resilience. And we are going to provide two examples of those. And the approach is the same. Either the training might be different, but the approach is the same. They try to, the community, the Red Cross, Red Crescent volunteer community, try to go directly through the community, through the last mile, as we used to say, to offer first aid training and first aid awareness session to those who cannot afford it or who cannot even travel due to unsafe road or unpracticable pathway for them. So that's important for the Red Cross to reach that community so that they are prepared in case of belly accidents or even a more important emergency like disaster or conflict. So they use an approach called community-based health and first aid training, which means that it's not first aid training, a regular basic first aid training, but rather make a training made with the community itself according to an assessment of risks, to an assessment of what they experience, but also to an assessment on what do they have at their disposal. Because you can imagine that, for example, cooling a burn, it's not, might be critical and challenging when you don't have runnable or potable water at your disposal. So we need to take that into account. For example, in Armenia, so Armenia is in Central Europe, and you might know that this country is prone to it's really prone to disaster, but also experienced recently an escalation of a conflict in the border with Azerbaijan, still in Central Europe, and it creates more and more isolation for communities living in this borderline. So they are at the same time challenged by a lot of natural disaster, but also by the fact that the roads are blocked because of the conflict. So the Red Cross decided to go directly to the community and buy what we call mobile health units, in which you can having first aid kit at your disposal and also materials in case of any emergencies. It can be also very important to have vehicles and ambulance parking there because of potential evacuation in case of such a conflict. But they wanted in Armenia to go further that providing material. They really wanted to have the community participating in their own, involving their own safety. So that's why they organized a lot of first aid training, focus on transportation of the patients, and also on CPR and use of first aid kits for wounds, burns, and bleeding, so that people, in case of an evacuation, they can actually act and try to maintain a life while waiting for further care. And this project was really successful because actually, the more people were engaged, it creates a great dissemination, because all the neighborhoods, all the other people wanted to engage more in that type of programs. And it results in more volunteers also for the Red Cross, because people wanted to be engaged more in the work of the Red Cross in Armenia and in the branches. So this is a good example of building resilience, and a good example of also trying to reach a community, but also to make them actor of their own safety. The conflict area is really difficult, because you have to think about also your safety first, not putting yourself in danger. So we try to, the Red Cross, and even with our guideline, we try to have that principle as a first step. But also it's really important to know about some techniques to actually transport victims to further medical facility. And if we take around in another part of the world, I wanted to bring you to Timor-Leste. So Timor-Leste is a country situated in Southeast Asia, near from Australia and Indonesia. And it's a country which experiences every month different type of disasters. So, for example, landslides or cyclones, and also tsunamis. This is an island country in which also the roads are really damaged because of those disasters, and because of lack of investment of the public government in it makes them impracticable. So here we have the same issue. We have the same issue of accessing a healthcare facility, accessing a hospital, and time of waiting for ambulance to arrive, or going even to the hospital itself, might be really long. So again, we have the same approach, going directly to the community, talking to them, and see where they live, what they are doing, and what material do they have. And in this example, you can see it on the photo. It's very interesting because they really work in teams. So the first step training is based on simulation in groups, so that everybody has a role while evacuating a person, or having or taking care of someone. So we can see on the photo that we have some improvised stretcher, and also some different people who are actually doing it. So that's for Timor-Leste, a great for those community living very far away from the capital. Very important to know about this technique, but also to build the confidence to do it, right? Because at first they think, I'm not able to do that. I'm not a doctor, and the only thing I can do is stay here and maybe doing some improvised treatment. But thanks to those works in team, and thanks to the work to the Red Cross and publication like the guidelines we have, we are able to provide more evidence and more advices for them to use the right techniques in the right times with what they have. Because this is the philosophy: rather do something with what you have than do nothing. So in Timor-Leste, it's really interesting, because now also the community, they can also teach to other community in the neighborhoods. And the only thing that might be taken into account for that project in the future would be to really have lifelong learning approach, because it's great to provide one time this training, but it's also good to maintain the knowledge. So I will stop here for the example. And if we continue our quick tour around, let's pass to African continent, and I will hand it over to my colleague Emmy and Irving.
Yes, thank you very much. I will just quickly share our slides and then continue with the presentation.
Just a technical problem.
Yes, if maybe you can quit the sharing, Salome and Emily, then we can share our screen as well.
Yeah, it's done. Do you want me to? Okay, all good.
Can you see our screen now?
Yes.
All right, perfect, great. No, thank you very much, Emily and Salome, for already pointing out that
Irving, we don't see your slide.
You don't see my slide?
It's black.
Now it should be there.
All right. So second start. No, thank you very much, Salome and Emily, for already pointing out that the one-size-fits-all approach is not always the most favorable approach, especially in a first aid guideline and education development context, and that we actually have to emphasize the importance of contextualization. And it is also something that we at the Belgian Red Cross find very important, and we try also to kind of have this adaptation to the local context in every level of a development of first aid guidelines and education. And one of the examples that we want to provide you today is actually the first aid education guidelines that we actually develop and implement in support of our partnering countries in the sub-Saharan African context. So before we start with the explanation about the different aspects when talking about adaptation of the local context in the development of context-specific guidelines for low resource settings, such as the sub-Saharan African context, it is maybe important to set the scene and to understand what kind of context we're working in. And that's also maybe an idea to understand why it's important to have these kind of context-specific guidelines and also training materials. If you look at the sub-Saharan African context alone, every year almost 5 million people die due to conditions that are actually preventable or maybe addressable by pre-hospital care or emergency care. But unfortunately, many of the pre-hospital emergency services were not readily available or often lacking. And so that's why patients are often or many times highly dependent of the immediate care of bystanders. But the immediate care of bystanders doesn't guarantee a correct outcome. So if you look at for example, to the panel on the right side, we see that for the first aid care that has been provided after a burn, only in 49 of the 168 cases, so less than 30% of the cases, water lavage has been provided, so that actually the burn was cooled with cool running water. So
Sorry, there's still a little problem. Sorry for bothering. We don't see it fully yet. We can't see your full presentation right now. Where is your Zoom? Let's try again. Okay, I'll see if it works now. Sorry for bothering.
So yeah, so the materials used are not often the most appropriate materials that are used. And it's also what we see, for example, with envenoming by a viper, where still in many cases black snake stone is used. So the importance of first aid training is not only because it's not only a way to decrease the burden on disease of injury in sub-Saharan Africa, but it's also important to have the best and most appropriate interventions taught to the public and to the lay people. And in order to have the most correct first aid interventions. And that is also why the Belgian Red Cross invests and also supports its partnering countries in the sub-Saharan African context in the development and the implementation of context-specific first aid materials.
Okay, in the next couple of slides, I'm going to illustrate you the different steps we took to go from evidence to context-specific guidelines and teaching materials, and more specifically for the sub-Saharan African context. So when developing evidence-based guidelines, the first step is always to collect the best available evidence. And for first aid guidelines, there is already a lot of evidence reviews and recommendations available through the resources of the ILCOR First Aid Task Force and the guidelines of the ERC and the IFRC that were just presented by Emily in the previous presentation. But in addition to a basic set of evidence reviews, or the so-called PICO questions, for a low and middle-income country setting or a low resource setting, it's very important to also think about additional, more alternative interventions, also to be covered by evidence reviews. And in the previous slide, Irvin already gave some examples of alternative first aid interventions that might be harmful as well. So it's important to also collect evidence on these interventions, mostly at the household level and with limited resources. So the Center of Evidence-Based Practice of the Belgian Red Cross already developed many of that kind of evidence summaries. It's maybe also important already in this very first step to discuss with local experts about these alternative topics or relevant interventions for the context of relevance. So after this first step of gathering the evidence, we want to translate the evidence conclusions and the evidence reviews into practical recommendations and first aid actions. And for the IFRC guidelines, we worked with first aid content experts from different Red Cross, Red Crescent national societies. But for the African first aid materials that we developed at the Belgian Red Cross, we worked with our colleagues from the first aid department and from the international department. And when drafting this first version of recommendations, it's important to take into account the preferences and the resources of the target group. And of course, preferences of the target group, actually the target group itself or local experts, they know the preferences the best. So we always work with a local expert panel. And this brings me actually to the last step, where we always organize a meeting, a consensus meeting with a multidisciplinary group of local experts. So in this case, African experts in first aid and emergency medicine. And we always try to involve our colleagues of our sister Red Cross and Red Crescent national societies in these panel meetings. The GRADE methodology is being used to make the translation from evidence into recommendations. And in this method, we always make the balance between the certainty and the quality of the evidence on the one hand, and preferences of the target group, the resources, benefits and harms in order to decide on the recommendations. But when developing guidelines for low resource settings such as sub-Saharan Africa, we often see that there is only limited evidence available or no evidence available. or the certainty of the evidence is too weak. And of course, for all these first aid interventions or actions, we want to know if it is relevant for the African context and if it is appropriate for the African context. And that's where we always try to formulate some good practice points. A good practice point is actually an important practical point on which the experts and the group reaches a consensus, and nobody is likely to question this particular point. So it's very important to formulate these good practice points together with the multidisciplinary expert panel, which of course represent the target group of interest. And in such a panel, we always involve first aid trainers, content experts, people with field experience, and also more academic experts to have a good balance and to have a multidisciplinary panel. So this is an example of a context-specific recommendation. It's about the transport of a patient or a casualty in case of spinal injury. We developed an evidence review on that topic, and we identified a couple of studies with very low certainty evidence for harm of sitting or crouching during the transport. So in the studies, this position, sitting and crouching, was compared to laying down, and we saw that laying was associated with a significant decrease of mortality. Then these conclusions were discussed with the expert panel, and they concluded that the potential harms of sitting, as was shown in the evidence, outweighed the potential benefits of sitting. Because when you're sitting, you can wear a seatbelt, so that's also an important item to think of. And then they also discussed that just laying down would be acceptable and feasible to the target group in the sub-Saharan African context. So that's why the final recommendation said that the person with a spinal injury should be transported in a laying down position, and that in optimal circumstances, this transport should be done by an ambulance. But of course, this is not always possible in the context. So in the material, in the guideline, it is recognized that the mode of transport could be something else based on what is possible in the specific context. So once we have guidelines adapted to specific contexts, we take the step to developing teaching materials. And when you want to develop teaching materials adapted to a certain context, such as the sub-Saharan African context, it's important to use drawings and pictures that represent your target group. So here we had some pictures and drawings, including youths, elderly, people from multiple backgrounds, just to represent reality there. We also used simple and clear drawings that are easy to copy because we knew that that was very important to the users of the materials. And materials were also translated into local languages, which is very important for the later step of implementation. So these are this is the result of the development of several materials for sub-Saharan African contexts. We developed a basic first aid manual, also materials to train children and young people, and also a manual for first responders, so a more manual more on advanced first aid interventions. In the next step, once you have the teaching materials, you of course want to use them in practice and you want to implement them. And then, of course, it's very important to test the materials in the local context where you finally want to use them. Here on the slide, you see some examples of pilot testing of materials in Malawi and Zimbabwe. And then this kind of pilot testings, they provided some useful insights, such as in Malawi, where we saw that actually there was too much content for the number of days, and we had to adapt the training duration. Also, another example is we had a drawing of a salt tub, and it was about developing a homemade ORS solution for diarrhea. And then people told us, this is not how we use the salt here. You have to represent it in another way. So these are, of course, very useful insights. Here on the map, you can see the countries where we are currently active with the Belgian Red Cross Flanders, where we implement the different first aid materials. I'll hand over back to Irvin.
Yes, thank you. So once we have the teaching materials, the next step is actually to apply these teaching materials to disseminate the appropriate first aid techniques to the target audience. Nevertheless, little evidence is available on ideal teaching methodologies, such as if it's better to provide the teaching of the first aid techniques via a blended approach, where you combine face-to-face as well as virtual learning, or if you only have a face-to-face teaching methodology. So therefore, it's important to investigate and measure the effectiveness of the different kind of teaching modalities to understand what works and doesn't work in a certain context. And there it's important to provide answers through primary research, and in the context of my doctoral project regarding first aid education in a sub-Saharan African context, and in close collaboration with the International Cooperation Department of the Belgian Red Cross, we are planning to start a trial where we want to compare different kind of teaching modalities, which is called the First Aid Blended Learning Trial, and actually the aim started with the more conventional first aid training that is given nowadays, which is a face-to-face training given over several days. And there we're looking for different kind of methodologies or modalities to provide this first aid training and to also reach out to more people, because with the classical face-to-face first aid training, it often happens that people cannot come to all the sessions over several days. So that's why there are some time constraints that we have to take into account, but also the location of where the training is given is sometimes also a hurdle to come to the classical face-to-face approaches. And a third hurdle third barrier that can pop up is actually the limited organizational resources are in place, such as a lack of certified trainers or training materials. So that's why we're looking for a novel approach, being the first aid blended learning approach, where we then kind of combine the face-to-face practical skills, but then only in one day, and then combine it with the digital learning, where people can learn first aid skills and knowledge and theory in a mobile application. This enables people to get access to high quality of first aid content through the mobile phone, but also enables to reach out to more people, and most importantly, to give the people some kind of a flexibility and autonomy to learn first aid at their own time and at their own pace. So in the FABLE trial, or the First Aid Blended Learning Trial, the ideal or the aim is to actually investigate the effectiveness of a different kind of teaching modalities, being the face-to-face approach compared to the blended learning approach in a sub-Saharan African context, being Rwanda in our case. And there we want to try to understand how learning outcomes such as knowledge or first aid related skills, or outcomes related to attitudes such as self-confidence and willingness to help change when kind of following one of the kind of first aid trainings. And therefore, in a pilot study, we'll try to understand a bit more about these learning outcomes using a 3-arms randomized control trial, where people are randomly assigned into 3 different groups. For the pilot study, we're planning to have about 72 students from universities in and around Kigali, which then would randomly assign in one of the intervention arms or groups, being the first aid blended learning group or the face-to-face basic first aid group. And then we have a third arm, which is a control arm, to see how the learning outcomes change over time when compared to a group where no training is given. So in the FABLE trial, or the First Aid Blended Learning Trial, the aim is to actually investigate the effectiveness of a different kind of teaching modalities, being the face-to-face approach compared to the blended learning approach in a sub-Saharan African context, and then combine the face-to-face And so to do so, to actually perform primary research in a certain context, being here the sub-Saharan African context, it is also key to have the relevant feedback and insights from local partners, such as the Rwanda Red Cross, who will then facilitate us with the training venue and the trainers itself, but also the advice and the feedback from researchers who are locally performing their research itself there in the local context, and which can give us some more insights of how to conduct research in the local context itself. And lastly, it's also important to try out or to pilot the instruments that you want to use for your research, such as in our case, which are questionnaires to measure the knowledge, or checklists to measure the skills of the participants of the study. Also, and this to try to pilot them and try out and find out how this can be ameliorated by trying them out in a local target population. So to wrap up and to conclude, a few take-home messages. So when we want to apply adaptation to the local context at the different levels of developing guidelines and training materials for first aid, it's important to have the relevant stakeholders already at the beginning of collecting the evidence about first aid and first aid techniques when translating them to the guidelines. And secondly, it's also important to have the guidelines when making the guidelines to make use of the local context itself and to see what works and what doesn't work, and to fill them actually into teaching materials. And when we have teaching materials, we eventually want to try them out in a pilot testing and to see how what works in the real context, and to facilitate the implementation itself. And there where we encounter gaps in the evidence, it's important to then have context-specific primary research conducted, so we can find out what works and doesn't work, and what kind of evidence we can then reuse to improve our guidelines. So then I will hand over the floor to Emily.
Let's share the screen again. So here we are.
Thank you very much. And I'm really just going to summarize a little bit here from what we've heard from Erwin and Emmy and Salome. So we've heard here that the evidence base surrounding these topics is pretty limited. And we know that mostly clinical evidence is often tested under circumstances where basic equipment is available and professional medical care is reachable within 15 to 20 minutes. But in our three contexts that we're discussing today, that is unlikely to be the case. And it's helpful that the evidence which is available is broadly really in agreement that ensuring the learner is able to prioritize care is fundamental. As we mentioned earlier, in conflict and sometimes disaster settings, safety and security is the priority. In remote places or in contexts following a disaster or conflict, when the immediate danger has perhaps receded, then prioritization of injuries and illness really comes to the fore. People in these settings will likely have to wait a significant length of time to receive medical care. Therefore, first aid providers should understand which actions they have to prioritize and beware of confounding factors such as extreme heat or cold, which can exacerbate the problems that they're trying to solve. So it's essential to ensure that learners understand why some first aid actions are a priority over others. And a number of authors point towards a focus particularly on bleeding control and on maintaining an open airway and shock. So the next important feature in the available evidence is the need to differentiate first aid education according to the learner's context. So for example, the programme for those living in a remote community should differ from one aimed at people visiting a remote area. And this point is particularly relevant to how a bystander might respond to an ill or injured person. In remote communities, People are more likely to know one another and know where they can get help and how they can get help. In contrast, individuals perhaps on short trips to remote areas, they need to find out in advance how to access help for themselves and help themselves, and also to be able to help others. And a third factor featuring in the literature is around the involvement of community in developing first aid education. And we heard that very loud and clear from Salome, from her examples of Armenia and Timor-Leste. Here, a co-production approach will not only unite the groups, creating an interdependency and trust and shared understanding of how to help one another in a crisis, it also capitalizes on local knowledge and on the rallying power that community leaders can have. Their influence can support a customized approach to first aid education, tailoring an effective and an efficient approach to public health and emergency response messaging. So, two key themes have emerged from the evidence, which in doing so also indicate the gaps and where focus really needs to be put for further studies and research. Firstly, adaptation. The evidence tells us to work with learners to understand their context and the resources that are available to them. Adapt the education accordingly, make sure that it's relevant to their reality and appropriate to their skills and their capabilities and their confidence. And secondly, empowerment. Emphasize that individuals can play a critical role in these contexts. It's their actions that can be the difference between life and death. As an educator, you should feel empowered to adapt your education approach to the content that's most needed for your learners. Give your learners the permission that they need to respond in the best way that they can, using the resources that are available to them, and take a humane and an intelligent approach, because always, but especially in fragile contexts, the stress of responding is enormous and should never be exacerbated by a fear of being without the equipment that you need, or distracted by the theories which you can't apply. Reviews of the IFRC guidelines have been and will continue to be published in the International Journal of First Aid Education. This is a free journal, it's free to access, it's free to publish in, and it's entirely volunteer run. So there are no conflicts of interest in terms of financial reasons. You can subscribe to it. You can also follow the journal on Twitter and LinkedIn, and in this way you can make sure that you're reading the most recent and up-to-date reviews of the evidence, and you can use these to shape your own research and to fill some of the gaps around the populations and approaches for first aid learning in different contexts. So I encourage you to have a look at the journal and see how you can become more involved, and in that way you can start to contribute your evidence to the creation of these guidelines. So thank you very much for your time and to all of our speakers, and I'll hand back now to our chair.
Yeah, thank you very much. Excellent presentation, very good examples also. So all of you out there, please write questions in Slido so we can ask them to the speakers. I can start. I have been writing both treatment recommendations and guidelines. And what I'm stuck in my head is this a problem or a solution? Like the guidelines, is a problem that you have guidelines and you want them to be global so everybody can follow them, but still you need to do something local to really adapt to the context. And that can be both necessary to get the context and get the acceptation for the advice, but still you want to be the global advice to be good enough to be global. Do you understand my question? Can you elaborate a bit on that? I mean, how diverse do they end up in the end?
If I may start and let the other continue on purely implementation. So the idea with the guideline is really to find evidence on eventual local measure that community can take, and to see if it's harmful or not. So what we are trying sometimes is really to collect those case study on how do you treat a burn, a wounds, etc., and trying to look for evidence. Is this working or not? And based on the evidence that is found in the guidelines, we are communicating with the focal point of the Red Cross and Red Crescent Society to make advocacy for evidence, science, and accurate literature on the technique we are advocating for them to use. And this is their role, to go to the country, the community they work with, to try to also disseminate that work of science. It's not always easy, and we have a lot of examples of a lot of methods that are used even in the community to treat certain disease or injuries. But it's the work that we are handling with the community to make them accepted or dissipate some myths that can exist around how to treat a person and how to take care of them. And this is really by having a link with this community, and this is the strength of the Red Cross. So this is for the how we can implement. Maybe Emily, you want to add on that?
I think just to say that the guidelines that we create are based on the first aid interventions that are required, most of all. And that outcome that you are looking for as the first aider doesn't change. We know that evidence. We know if somebody is bleeding, the outcome you need is to stop them bleeding. It's not to tie a perfect bandage. It's not to use a particular material. It's to stop the bleeding. And so the guidelines that we create are always directed at that outcome, to stop the bleeding. And I think what's difficult is that we don't have enough ways that we don't have enough evidence of all the different ways that people can apply these things. And that's why we want to involve more and more people. But we know that you have to put pressure on the wound to stop the bleeding. And so getting the evidence on how to do that and how to teach people to have the confidence to do that, that's really what we're looking for through the evidence.
Excellent. Emily or Irvin, would you like to comment?
Yes, maybe for the sub-Saharan African materials, even when you compare different African countries, there are different needs. So first we thought we just develop a teaching manual for sub-Saharan Africa. It is adapted for sub-Saharan Africa, but then we see that in the different national societies we work with, that there are still different needs and sometimes the need for different topics, so that we still have to differentiate even more. So it's really important just to hear what the local needs are, and then to work with the people there to develop something that is useful for them.
Very interesting.
A complementary question for you, and it's in terms of pedagogical approach. What do you think we can do, because we have not enough evidences in terms of expert opinion? Well, how we can obtain more confidence to act, more willingness for these population, fragile environments or effectively remote area? Do you think we have some pedagogical approach who are better than others to be better in terms of educators?
I think there.
Yeah.
Yeah, thank you. I think there, as emphasized during the presentation as well, the need for looking for evidence and identifying evidence in the field itself is crucial. And their primary research can be actually applied to find out what kind of modalities of teaching, where can it be through a face-to-face with a person really, or virtually in a virtual environment. By applying these in this kind of context, in this kind of in the regions kind of, and applying research in those settings, and finding out what works and doesn't work. It can perfectly be that a blended approach of teaching first aid works perfectly in a setting such as in the European setting or in a Western setting, as figure of speech, but it's less common or less productive or less effective, I would say, in a setting in East Africa or somewhere else in the world. So that's why primary research and this kind of testing of the modalities is kind of key and crucial in identifying and also generating evidence.
Even if there are not enough resources to do primary research and not enough time. Even if you don't have enough resources to do research, it's just important to gather data and to measure more and just to learn from it. So this is also a call to just teach, try things out, but measure and try to publish and make your results available so that we can learn from it. Because for the remote settings, there is indeed not enough evidence available, but it shouldn't stop people from teaching and trying but evaluate what you are doing and try to learn from that and just close the cycle and improve again.
What I see from the International Journal of First Aid Education is that there are some really, really fantastically creative ways of teaching first aid across the world. And the challenge we have is that usually the people who are teaching in those ways, they are not academic, they're not in research organizations, they don't think of themselves as researchers. And what they're doing is a fantastic job locally, but nobody is recording it. And I think that's what we're really struggling with, is how do we capture that information? So the journal that I've mentioned is one way. We welcome views from the field, we call them, those kinds of papers where people can tell us their story. But also the GFARC has an outcomes measurement toolkit, which it has in many different languages, and it encourages people just to do quite simple measurements of teaching one way versus teaching another way and seeing what the effect is. So like Irvin is doing, but on an even a smaller scale, where somebody is just collecting a small survey of people of, how did you find it? How confident do you feel having learned? Or how might you change your behavior now that you've learned? And it's those sorts of results that can, if we can collect those together, they start to add to the body of evidence that we can then draw on, and we can work with academics then to test these much more thoroughly and create that evidence base. But you're absolutely right. It is a challenge, particularly, as I say, because some of these brilliant practitioners in the field are not writing down what they do, understandably, and so it's hard to collect that insight.
I'm stuck with this, that we do not have evidence for things, and I wonder about that. Is it actually, we are in a scientific congress right now, but what about other ways of gathering what people do? Local people have local traditions and they have been doing it for so long. Do we have a responsibility, we researchers, to actually study it? And if they use toothpaste on burns, for example, is it our responsibility to take the toothpaste up to our laboratories and do the studies and see if it works? Or how do we do this? Because we always say we lack evidence, but people are doing a lot of great stuff out there and they don't publish it in papers, which is our evidence. What is your aspects of this?
So this whole methodology of developing evidence-based guidelines it starts with collecting existing evidence. So maybe there are some studies. We know that there are some studies about using potato peels on burns and so on. So there is something available. The studies that are available, I think we all know them in the meantime. But then, yeah, indeed, we see there are many gaps. But this methodology of evidence-based practice, it allows you to fill the gaps by working with local people, just based on their daily experience, by discussing it with them, and based on their daily experience to recommend something. And then, yeah, the next step is, of course, to encourage people to indeed to study it. But that's not easy. But there is still a lot we don't know. So while waiting for more research, we just base the guidelines on what people tell us, and on based on what they experience and what they see, and that is what we call the good practice points. And if more and more evidence becomes available, we update the evidence reviews, the guidelines, the teaching materials. But it's not easy. It's a challenge.
And I also wanted to add that at the moment, the IFRC guidelines are based almost entirely on English evidence, English written evidence. And we know that there are publications in other languages across the world, and we're really keen to be able to use those evidence papers as well. And so, again, we need more people to be involved in the evidence review process so that we can look at papers that are not translated and papers from other countries. And indeed, where there are researchers who might not be able to publish in an English-speaking journal, maybe they can publish in their own language. And certainly in the journal that I run, we try to publish the abstract of every paper we publish in the home language of the author. And that's another way to try to encourage this. But I think that is a really important point. And the other point that I wanted to just make was technology is improving, and technology allows us to collect data a lot more easily. And so I think it would be interesting to see how research develops to be able to capture more results, more data from people who can just fill out a quick survey on their phone or something in order to add to that evidence base. And perhaps we need to be thinking more creatively about how we use different methods of collecting insight from people in order to strengthen the studies that are being done or need to be done, or even inform what the studies are that need to be done.
Thank you, Emily. Jacqueline, you have a question, I think so, no?
Yes, please. Thank you very much for your talks. Very, very interesting points that were touched on. Might I just ask, what would be your key message for first aiders, particularly in a local setting where they might feel responsible for their own communities, within the whole what you were emphasizing about check for safety first? So what would you tell them when they come to a situation and it's sort of, okay, there's no obvious fire, but that might not still classify as a safe environment, yet there's that sense of responsibility for their community? For all of you.
It's this principle of take your own safety first is really important, because I mean, we have one wounded, but we can have two if we don't evaluate properly the situation. No, but I would say that for the first responders, if they are not trained or have been trained, maybe really in basic first aid training, and they are lay people, as we used to say, I would say that knowing the risk and prevention is really important, and this is in what we call the chain of survival behavior in our guidelines. So prevent and prepare is really key here, because when you are on the scene, you can be panicked, even if you are super trained or even not or it's the first time that you face an emergency. So knowing your context, knowing where you live, knowing about the risk, this is the key to avoid actually to use first aid. So sometimes the conflict we are talking about here in remote conflict and disaster, it's true that you cannot avoid that type of things arriving to you, because it depends on a lot of factors, sometimes geopolitical, sometimes climatic factors. So preparation is important, and you can prepare you can be prepared, being trained and being also refreshed regularly, and having different, for example, first aid app, or going to online courses. We do have that at the IE4C as well. And it's important to regularly maintain that, because once you need it, you are more confident and and you have the willingness to help in that case. So maybe that can be a start for a first message. Don't know if someone would like to add something.
If I can ask Arvin and Prof. Emi, do you think there's a particular teaching modality that would be most suitable to emphasize the importance of safety?
Yeah, I think in general, in the content of the trainings itself, you have the principles and those different steps that are actually emphasized by the training itself. And if we can also put more effort into providing these steps, maybe throughout the whole training, and emphasizing on the safety procedures, if we can put more emphasis in different kind of modality itself, I think it's just a content related topic, rather than more of a modality or a way of teaching.
I think we can also look to water safety as being perhaps the leader in this particular for this particular question. I think right from being a small child, you are taught if somebody is drowning, you don't jump into the water to rescue them. You find another way of getting them out of the water. And this is exactly the point. You need to find a way to help without putting yourself in danger. But as Salome said, you don't want two victims here. you need to make sure that you keep yourself safe.
So thank you very much. Just to underline what we said concerning droning, or for all people who are listening to us, you can find in the WHO website a new guidelines concerning droning, and evidence-based and very interesting publication of the WHO on the field of water safety. So, Therese, what we can say, we have just some 2 to 3 minutes more now.
Yeah, I think this was an excellent session, and I really think that you gave good examples on the problems and how to solve them. And we really need to find new ways to get more evidence, and that's we need to collaborate. And I think that's excellent to do in this world we are living now, with the global perspective. So I really thank you for your sessions, and wish you good luck, of course, in the future, and hope to see you again. Any final words from you, Pascal?
Yeah, the same. Thank you very much from this very interesting discussion, and it's really important to have that in mind, because more and more this world is terrible with the climatic environment and other environment of crisis we know, and so not so very far in Europe. So it's really important to adapt our pedagogy, our techniques according to the environment, taking into account the most fragile people of the world, and to disseminate first aid for everybody. Jacqueline, you are the youngest of this panel, and please give us the future, your feeling for the future of first aid education for remote area and fragile environment.
Feeling very inspired after all of these interesting talks. Some very, very important content and some very important information given out today. I look forward to seeing all of these drawings on the guidelines as well. I think that's a very innovative way to get impressions and to really spread the message. Thank you for being with us, all of the panelists today and the moderators, and thank you as well to the audience for coming in to listen to the session. We hope that you learned something and that you enjoyed it.
Thank you very much.
Thank you.
And bye-bye.
Bye.
Bye.
Thank you. Bye.